is there a way to bring down plaque? I mean, through pharmaceutical approaches, or are there any alternative approaches? Would you like to shed some light on that, please?
Yeah. So, as far as there is this PACE study, when there was non-coronary plaque, early evidence of non-coronary plaque, in about 8% of those people with aggressive lifestyle measures, they were able to, upon repeat imaging, actually have no detectable plaque. So can you really get your act together if you've got some plaque, and potentially reverse that with aggressive lifestyle measures without medication? I think it is possible. With coronary plaque, I don't think we have data beyond pharmaceuticals to say, hey, can we stabilize this plaque and even lead to plaque regression? There's some, we know statins do some things I don't love, as far as the skeletal muscle mitochondrial stuff, and as far as the worsening insulin resistance, but it's dose dependent. So have I prescribed statins? Yes. Statins are not like the devil, and it's not like they're the cause of all existential angst, but I do believe that using a statin in combination with other medications to minimize the dose dependent side effects is really, really smart. I try to be combophilic rather than focus on whether it's hydrophilic or lipophilic, which are different characteristics of statins and their solubility properties. I say, hey, the most bang for your buck with a statin, which does stabilize plaque. If you have, if you've been broken into, do statins do a nice job of stabilizing your plaque? Yes. And so I like that. And, if you've been broken into, well, there's some pretty good data on this actually, helping your problem. However, we know that the most bang for our buck as far as reducing the amount of criminals in your corrupt workforce is the initial dose. And with every subsequent doubling, you get maybe 6% additional LDL-C lowering, and then you increase the side effects quite a bit. For instance, there was a recent meta-analysis, over 120,000 patients in statin trials. Over 5 years, new onset diabetes with a moderate intensity statin, which an example of that would be like rosuvastatin 5 milligrams, 10%. Okay, that's not crazy as far as, general population. And with a high intensity statin, which would be rosuvastatin 20 or 40 or atorvastatin 40 or 80, 36% increased risk in new onset diabetes. So, you're not getting a whole lot more LDL-C reduction there, but you're increasing your side effects quite a bit. So, do we want to do that? Well, I would say that that's not the best approach outside of acute coronary syndrome. The data is there for high intensity statin versus lesser intensity when someone has just had a heart attack. Okay. So that's a different context, right? But if we're just trying to identify things before you have the heart attack and you have evidence of plaque and we have decided that, hey, we want to start this, well, okay, let's use a lower dose and then maybe combine it with something else. Because when you have been broken into, your body fights you if you're trying to move. And we know this because people, they're living in this rough neighborhood, but this is home, darn it. I want to stay here. And so what happens when you reduce cholesterol synthesis with a statin, what does your body do with cholesterol absorption? It increases it. It's fighting you to stay in this rough neighborhood. Well, what do we do to decrease cholesterol absorption? There's a drug called Ezetimibe or Zetia that is a cholesterol absorption inhibitor. And hey, Ezetimibe really is super clean, very well tolerated, no real side effects. And so you can get people to wherever your lipid target is as far as their goal better, have the person tolerate it better, run into less new onset diabetes, and with that combo approach rather than just blitzing everybody with your King Kong statin dose. So I think that's a smarter way to play that game if we're talking about those particular tools.